Okay, I think then you can start with you could talk. Yeah.
Hello everyone, I'm Wu Boyi, the second-year resident from Linkou Chang'e Memorial Hospital, Taiwan. So today my topic is clinical characteristics, treatment, and outcomes of cytomegalovirus anterior uveitis, a multi-center study in Taiwan. I deeply thank Professor Huang Yizhou and Dr. Kang Youxuan for their guidance in this research. So we aim to compare the efficacy of the topical and oral antiviral treatment in patients with cytomegalovirus anterior uveitis in Taiwan. We obtained our data from the Chang'e Research Database between 2007 and 2019. So we enrolled the patient tested positive for aqueous CMV PCR, and we excluded the patients with retinitis, identified by either the ICD diagnosis codes or the history of intravenous ganciclovir use. And the rest of the patient is our target population, the patients with anterior uveitis. Because the ocular examination results were unavailable from our database, so we used the medication usage pattern to define the patient's uveitis course. So for those who had no anti-CMV medication prescription within 3 months after the diagnosis, they were classified as having an acute course of uveitis. While the patients having history of anti-CMV medication re-prescription after ever having medication cessation for more than 3 months, they were classified to have a recurrent uveitis course. And the rest of the patients, they were classified to have the chronic course. So in total, we identified 240 patients. The mean age was about 58 years old, and 77% of the patients were male. The mean follow-up duration was about 4 years. And regarding the medication use within 90 days after the diagnosis, half of the patients were on topical ganciclovir, and about 40% of the patients used the oral ganciclovir, and 1/3 of the patients underwent the intravitreal ganciclovir injection. And 60% of the patients received topical corticosteroids, and the mean number of anti-glaucoma medication per patient was about 3. Regarding the outcomes, within 3-year follow-up, glaucoma intervention, surgeries, or laser were required in 13% of the patients, and corneal transplantation was performed in 12% of the patients. If we stratify the patients based on their initial treatment within 90 days, we have 3 groups. The patient that received the topical ganciclovir only, oral ganciclovir only, and those who received the combination treatment. So we discovered that the topical ganciclovir only group, they had the significantly shortest follow-up duration compared to the rest of the 2 groups. Regarding the uveitis course, the patients that received the oral ganciclovir only, they had a significantly higher proportion of patients having the acute course compared to the topical ganciclovir only group. And the combination treatment group, they had the lowest proportion of patients having the chronic uveitis course. So patients initially receiving the oral ganciclovir, they were less likely to develop a chronic or recurrent uveitis course compared to those receiving topical ganciclovir only. And regarding the complications, within 3 years, the patient that received the oral ganciclovir only, they were less likely to develop ocular hypertension or glaucoma. The efficacy of oral ganciclovir in preventing glaucoma surgery has been demonstrated in the literature. However, this effect was not observed in the combination treatment group. And so this may indicate that some factors other than the initial medication treatment may have also played a role on the long-term outcome. And the cataract and the rest of the surgeries and the proportion and of the laser did not differ significantly between the groups. And if we stratify the patients based on their uveitis course, 1/5 of our patients had a chronic course, 1/3 had an acute course, and half of the patients had a recurrent course. And among these patients, about 1/3 of the patients, they had more than 3 times of the disease recurrence. So regarding the use of anti-glaucoma medication as 3-year follow-up, the recurrent group, they were in need of more anti-glaucoma medication compared to the rest of the 2 groups. And regarding the complication and within 3 years, the recurrent group, they had the highest proportion of developing ocular hypertension or glaucoma, and they were also in need of more corneal transplantation compared to the rest of the 2 groups. So patients with recurrent course of anterior uveitis, they had the most glaucoma and corneal decompensation within 3 years. Certain limitations exist in our study. So first, the uveitis course was classified by medication usage patterns, and bias may have arisen if some patients were receiving prophylactic anti-CMV medication during the stage of disease quiescence. And also, there was a lack of standardized treatment and follow-up protocols across different ophthalmologists, particularly in a disease with such a wide spectrum of the clinical presentation and the disease course. So in conclusion, compared to the topical ganciclovir alone, initial oral valganciclovir has the potential to avoid a recurrent or chronic disease course. And the recurrent anterior uveitis episodes were associated with an increased risk of ocular hypertension, glaucoma, and corneal decompensation. So this is my presentation, and thanks for your attention. I'm open to questions.
Thank you so much. So may I call the next speaker? So it is tocilizumab for cystoid macular edema secondary to immune recovery uveitis in a patient with contraindications to long-term systemic corticosteroids. Please.
So hello everyone, my name is Trung Nguyen from Vietnam. So today I will talk about the use of tocilizumab for CME secondary to immune recovery uveitis in a challenging pediatric patient presentation. This is my financial disclosure presentation. A 16 years old female patient complained about decreased vision in both eyes. The patient was diagnosed with acute T-cell lymphoblastic leukemia and has been on chemotherapy for 6 months. Patient had systemic steroid-related bilateral hip osteonecrosis. On examination, the anterior segment was unrevealing. Fundus photo of both eyes show frosted branch angiitis and peripheral necrotizing retinitis with hemorrhage in the temporal and nasal side. OCT finding show temporal retinitis with atrophy both eyes, along with epiretinal membrane and subretinal fluid in the right eye. So the laboratory show a significant leukopenia and a remarkable reduction in CD4 level. CMV, IgG, and IgM were positive, and CMV DNA were detected in both plasma and aqueous fluid, confirming the diagnosis of CMV retinitis both eyes. The patient was treated with foscarnet intravitreal injection both eyes, with 2 injections given, and IV ganciclovir for 3 days, and then followed by oral valganciclovir. 2.5 months after the treatment, the frosted branch angiitis and the retinitis resolved with no active lesion. The macular OCT was dry and the VUs were acute in 2020. The patient was stable until 3 months later. The patient again complained about decreased vision in the left eye. At that moment, the patient was 2 months post chemotherapy and 1 month after discontinuation of valganciclovir. Her white blood cell count has returned to normal and the CD count has increased. CMV DNA plasma were not detected. Fundus photo show resolved retinitis, maybe temporal macular atrophy, some residual scar in the nasal side of the left eye, and there's some new area of sitting vessel, and OCT show a recurrent intraretinal and subretinal fluid. The left face fluorescein angiography show optic nerve leakage and peripheral perivascular leakage both eyes. So the diagnosis of immune recovery uveitis were made, and the treatment included restarting oral valganciclovir, IV methylprednisolone Q4 weeks. However, after 2 cycles of IV methylprednisolone, the patient had side effects like muscle pain and headache. So we decided to switch to IV tocilizumab at the dose of 8 mg per kilogram Q4 weeks. And after 3 cycles of tocilizumab infusion, the optic nerve leakage and the peripheral vascular leakage have improved, and the uveitic macular edema completely resolved. So discussing immune recovery uveitis is the ocular manifestation of immune reconstitution inflammatory syndrome. Treatment for IRU, corticosteroid is the mainstay. However, its use can be challenging in a young patient with clear lens and significant history of side effects. Anti-CMV therapy can help to decrease the CMV antigenic load and avoid CMV retinitis reactivation. And the successful use of intravitreal anti-VEGF injection in the management of CME induced by IRU has been reported. So evidence for anti-IL-6 therapy, IL-6 level were found to be higher in the aqueous and visual fluid from patients with IRU, suggesting IL-6 play a role in the pathogenesis of IRU. And stop uveitis randomized clinical trials show that tocilizumab infusion at 4 or 8 mg per kilogram Q4 week lead to improvement in CME when managing active non-infectious uveitis. And the study was conducted by French Uveitis Network show that tocilizumab seemed to improve complete response of uveitis macular edema compared to anti-TNF alpha agent. So conclusion, CMV retinitis can occur in patients with immune deficiency. IRU is a sight-threatening complication and should be carefully monitored. And IL-6 receptor antagonist could be a therapeutic option for CME induced by IRU. So I would like to say thank to Professor Quan Dong Nguyen and my colleagues at Nguyen Eye Lab, Bio Eye Institute, Stanford University, for giving me a wonderful opportunity to participate in this case. And thank you for attention. Yeah. Okay, I'm open for the question now. Okay.
Thank you. It's wonderful that Okay, thank you for the presentation. It's wonderful to see that tocilizumab works quite okay. It's also our experience that tocilizumab perform, I think, the best compared to anti-TNF.
Yeah.
And I would like to ask if you give this tocilizumab, for how long you give it, and did you taper after like 2 years, and how you step down if you need you decide to discontinue? I mean, because you directly go to tocilizumab, did you also consider to switch to DMARS or try to with low dose methylprednisolone before stopping? But usually we prolong the interval, and then after a couple of period when there's no activation, then we directly stop. But I would like to ask how you do with your patient. Thank you.
Okay, so thank you very much. That is actually a wonderful question. So I would like to answer, because of this patient is very challenging, and the patient had so many systemic problems. So initially, when we make a diagnosis of immune recovery uveitis, also the CMV retinitis reactivation was put in the consideration. So at the beginning, because this situation is sight-threatening complication, so we just try to put the patient on IV methylprednisolone first, because we want to something very strong and very fast to save the visual acuity. And then when the patient developed the side effect, so we switch to tocilizumab. But actually, this patient have some very difficulty to accept the insurance to cover the biologic. So after only 3 cycles of tocilizumab, so the patient have to stop it. And then now I think around maybe 1 year after the infusion, the tocilizumab infusion, and the patient seem doing very okay without systemic and ocular side effect. So this is only a key report, and we still have a lot of limitation. So yeah, maybe we need to perform more study about it. Thank you very much.
Thank you so much. So the next speaker is Zhenzu Zhong. He'll talk about the comparative effectiveness of immunomodulator agents plus corticosteroids for severe Behçet's disease uveitis. I think the speaker is not available, but he has sent us a recorded video. So we can just have a look at the video and just see.
Hello, ladies and gentlemen. Thank you for giving me the opportunity to present our study on the comparative effectiveness of immunomodulatory agents combined with corticosteroids in treating severe Behçet's disease uveitis. I'm Zheng Zhong from the First Uveitis Hospital of Tongji Medical University. Today, I will walk you through the key aspects of our study step by step. Let me start with the background of our study. We study the uveitis, particularly when it involves the posterior segment, is a challenging condition to manage. Despite use of corticosteroids, relapses are common and the long-term outcomes remain suboptimal. The EU LAR recommends corticosteroids should be used in combination with immune modulators. However, there are few data from clinical trials to determine optimal therapeutic management. This leads us to compare the effectiveness of three immunomodulatory agents: cyclosporine, interferon alpha-2A, and adalimumab when combined with corticosteroids in patients with severe disease uveitis in a head-to-head randomized trial. Now let's move to the study that participates. Our study was a randomized controlled trial involving 270 patients. These patients were randomly assigned to one of three treatment groups with 19 patients in each group. All patients were aged 18 years old or older, had severe basic disease uveitis, and were on corticosteroids but led to anti-TNF therapy. 261 patients were included in the full analysis stage, which includes all randomized assigned patients who had at least one post-baseline assessment. This analysis was conducted according to the intention to treat principle. Let's look at the baseline characteristics of participants. The mean age of all participants was 38.1 years. The cohort were predominantly male, and all participants were East Asians. Importantly, all patients presented with posterior segment inflammation and had a median duration of uveitis of 14.3 months. Patient characteristics were well balanced, ensuring a fair comparison of treatment outcome. Let's discuss treatment protocol. The cyclosporine patients received it at a dose 2 to 5 milligram per kilogram per day. In the interferon alpha-2A group, patients received it at a dose of 3 million units per day. In the adalimumab group, patients were treated with adalimumab at 14 milligram every 2 weeks. All patients continued taking prednisone at their trial entry dose, with the goal of tapering to 7.5 milligram per day over time. Moving on to primary outcome, we focus on the annualized relapse rate of uveitis. This was defined as the average number of relapse during treatment period, standard by year. A relapse was determined at each visit if any of the following criteria were met in either eye, involving anti-chamber cell score, vitreous hair score, and inflammatory lesions. The annualized relapse rate from baseline to month 6 was 1.84 per year in the cyclosporine group, 1.44 per year in the interferon alpha-2A group, and 0.95 year in the adalimumab group. Our findings demonstrate that combination of adalimumab with corticosteroids significantly reduced annualized relapse rate compared to cyclosporine plus corticosteroids. This suggests that adalimumab plays a crucial role in achieving better disease control and improving outcomes for patients with severe disease uveitis. There was no significant difference comparing the interferon alpha-2A group with either adalimumab or cyclosporine group. In conclusion, adalimumab plus corticosteroids was superior to cyclosporine plus corticosteroids with respect to uveitis relapse rate. Our study highlights the importance of incorporating adalimumab into the treatment strategy for severe disease uveitis. This approach not only reduces frequency of relapse, but also enhances the overall management of this condition. Finally, I would like to acknowledge the contribution of my colleagues and the patients who participated in this study. Thank you for your attention.
So anybody wants to discuss anything on the same? Any other particular preference you have for Behçet's disease? I think we have a pretty good experience with azathioprine also, and we give it for a long term, and I feel our patients are also doing fine. But yeah, adalimumab has a role in preventing the relapses over a long period of time, and I think it should be tried, as the speaker has already told. The next speaker is also has a recorded presentation. So the topic is sex-specific neutrophil subset determination to determine the immunological outcomes in Behçet's uveitis. Dr. Qingfeng, yeah.
Good morning, ladies and gentlemen. Today I'm going to talk about our research on sex-specific neutrophil subsets determining the immunological outcome in Behçet's uveitis. First, let's start with the background. Behçet's uveitis, or BU for short, is one kind of autoinflammatory disease. It's one of the most common and vision-sensitive uveitis endotypes in China. Both innate immune and adaptive immune responses are involved in it, especially neutrophils and CD4 T cells. Clinically, we see that males have a higher incidence and more severe disease. We wonder what are the exact mechanisms behind these sex differences. Are neutrophils involved? We first conducted a retrospective study with 1,881 BU patients. We looked at their ocular examination results, clinical manifestation, and routine blood tests. We also did some experimental work like measuring Th1, Th17 Treg cell differentiation and net production. Our results showed that males have more severe systemic manifestations such as skin lesions. They also have a higher neutrophil number in their blood test, and the higher neutrophil number is associated with a higher blindness risk in male patients. We also found sex differences in CD4 T cells and neutrophil responses. Male patients have higher net production from neutrophils, and they have a lower percentage of Treg cells. So we started to think about the role of neutrophils in these sex differences. To investigate this, we did single-cell sequencing on neutrophil from female and male BU patients. We found sex-specific neutrophil composition. These neutrophil subsets can be clustered into conventional and unconventional subsets. Among them, inflammatory neutrophils were higher in males, while interferon responsive neutrophil and T-cell regulatory neutrophil were much lower in males. We also found that interferon called random neutrophils a more immune regulatory phenotype. There was a positive relation between these two unconventional neutrophils. Interferon can induce T-cell regulatory neutrophils and Treg differentiation. Next, we looked at the role of T-cell regulatory neutrophils in the Treg differentiation. We used a conditional knockout model of T-cell regulatory neutrophils in an EAU model. We found that knocking out T-cell regulatory neutrophils enhanced Th17 Treg cell imbalance in the EAU model. Then we did an adaptive transfer of T-cell regulatory neutrophil in the EAU model. This helped recover Th17 Treg cell imbalance in both female and male EAU models. However, when we treated EAU model with interferon, it couldn't recover Th17 Treg imbalance if the T-cell regulatory neutrophils were knocked out. This means that interferon treatment relies on the presence of T-cells regulatory neutrophils. Finally, we tried to find out the potential mechanisms behind the defect of unconventional neutrophils in male patients. We did a GWAS on sex differences in the genetic background of BU patients. We identified 120 male patient-specific SNPs. One of these SNPs is associated with suppressed type 1 interferon pathways in neutrophils. We also looked at DEPs and microRNAs of exomes between male and female patients. We found that type 1 interferon pathway in neutrophils was suppressed after co-culture with male patient-derived exomes. To sum up, our research shows that the male bias severity of BU is positively associated with neutrophil responses. The unconventional neutrophil subsets, especially T-cell regulatory neutrophils, are defective in male patients. These neutrophils play an important role in regulating Th17 Treg cell balance and the treatment of interferon. The male patient's specific genetic background and exomes may suppress the unconventional neutrophil differentiation. Many thanks to my tutor, Professor Yang, and our research teammates. That's all for my presentation. Thank you for your attention.
Thank you very much, Dr. Chi. Now we move on to any questions for Dr. Chi? Now we move on to the next paper, FP3145, carbonic anhydrase inhibitor for management of uveitic macular edema, a systematic review and meta-analysis by Dr. Tiffany from Excel India. Dr. Tiffany, please. Is it recorded or Tiffany, is you are here? Okay.
Afternoon, all the doctors. Thank you for your time. I'm Tiffany from Indonesia. On behalf of my mentors that made this presentation possible, here I want to present our review and meta-analysis titled Carbonic Anhydrase Inhibitors for Managing Uveitic Macular Edema. There is no conflict of interest. So, uveitic macular edema is a common complication leading to vision loss in uveitis. The pathomechanism involves inflammation that leads to disruption of the blood retinal barrier, resulting in the fluid accumulation of the macula. The management for UMA still remains challenging as there is still no consensus for it. The first-line steroid might lead to another steroid resistance, and their long-term use might lead to another ocular complications. While other alternatives are relatively inaccessible, especially in low and middle income countries due to their high cost. Inhibiting carbonic anhydrase has been estimated to improve macular edema in some experimental settings. Therefore, we aim to summarize current evidence of the use of carbonic anhydrase inhibitors, CAIs, for managing UME. We followed PRISMA guidelines, identified papers from 6 databases. Title and abstract were then evaluated, followed by full text assessment according to predetermined eligibility criteria. Meta-analysis to pull selected outcomes proportion using random effect model was then performed and followed by head-to-head comparison when applicable. So, Robbins' eye tool showed varying level of bias from low to serious, with one identified with serious risk. Only 7 papers were found to be relevant, with a total of 187 participants, still scarce and rather overlooked. And most subjects had chronic episode of uveitis, with non-infectious idiopathic as the leading cause. Majority were white, mainly were middle-aged adults, and women proportion was slightly higher than the men. All studies used oral acetazolamide with range dose of 500 to 1000 milligrams per day in divided dose and varying follow-up times. You can see here 3 crossover compare acetazolamide with placebo, and all studies allowed any previous and concomitant treatments. The final general outcomes were then categorized into 2, which is visual and anatomical improvement. So, from data extraction here, we can see that 5 of 7 studies showed improvement. First, in terms of visual acuity, 2 using logMAR notation, and the rest were based on line gain on Snellen. And secondly, by anatomical, using CST measurement in 1 study and leakage reduction in 2 studies. One study by Sealing, here the second one, reported functional improvement of both visual acuity and anatomical in 53% of their subjects. and saw anatomical without visual gain in 28% of their subjects. Recurrence were discussed in 3 studies, and they showed that maintenance doses were needed to retain their therapeutic effect. Pooled proportion for visual improvement using acetazolamide was 53%, indicates half the odds of acetazolamide benefit in improving visual acuity. Head-to-head comparison from 2 studies showed risk difference of 14% likelihood of improved visual acuity using acetazolamide when compared with placebo. For anatomical improvement, the proportion was quite promising at 55%, indicates that more than half of the population showed anatomical improvement with acetazolamide administration. Onset and inflammation activity were discussed in 3 studies. One study showed that improvement was better in acute active UME than the chronic ones, while the others show no difference between the 2. Pre-treatment severity was also proven to be not predictive for treatment response in one study, while in another, age was found to be a significant predictive factor, as subjects under 55 showed better improvement than those who were older. For side effects, gastrointestinal complaints are found in all 7 studies, while paresthesia is the leading effects found in 3 studies. Severe side effects were dehydration and intolerable allergic reaction. So let's do a quick refresh over UME pathomechanism. Carbonic anhydrase enzyme catalyzes a process which product plays important role in the fluid transport, and this enzymatic activity also present in ocular, including in Muller cells and also RPEs, which plays important role too in generating UME. Although the exact mechanism still remains elusive, CAS works in inhibiting this enzymatic activity will alter the fluid movement, which is likely to cause improvement in UME itself. The reported side effects are also understandable, as CAIs can alter fluid and acid-base balance, but they are generally mild and do not affect the treatment significantly. So we believe that this is the first study to provide quantitative evidence regarding this topic, but we still have several limitations, including limited number of studies with high variability across them, and our reliance to secondary data, which also only report acetazolamide as the only CAIs. So as the conclusion, CAIs, specifically oral acetazolamide, offer a potential alternative with mild side effect for UME, and this can be beneficial for patients who are refractory to steroids or are steroid responders. But further well-designed studies are still required to better evaluate the efficacy and safety of this treatment. So maybe that's all from me. Thank you for your kind attention.
Thank you, Dr. Tiffany, for the excellent presentation and a great literature review. Any questions to Dr. Tiffany? If not, we'll go to the next present paper. Next paper is a quantitative assessment of peripheral choroidal vasculature on UWF ICGA in posterior uveitis using advanced imaging processing techniques. Presenting author is Dr. Ashish Markan. Dr. Markan, please, is there?
Yeah. A very good morning to all. So I will be talking about the quantitative assessment of peripheral choroidal vasculature on ultra-wide field ICG in posterior uveitis using advanced image processing techniques. So we all know that with the emergence of ultra-wide field ICGA, it has broadened our analytical scope to enable us to study the aspects like the vortex vein ampullas, the choroidal drainage and the outflow, and the morphology and dimensions of the vortex vein in various diseases like PCV and central serous chorioretinopathy. But there is currently a lack of data on the quantification of these parameters in posterior uveitis. So the present study aims to bridge this gap by quantifying various peripheral choroidal vascular parameters using ultra-wide field ICG in eyes affected by posterior uveitis. So this was a retrospective study. All the patients, they underwent FFA and ICG. Images from the intermediate phase were taken. Only well-centered images with visualization of minimum 3 vortex vein ampullas were included in the study analysis. And the Python program was used to study the choroidal vascular parameters. Images with poor fixation, with media opacities, eyes with other ocular comorbidities, and poor imaging quality, they were excluded from the data. What were the 4 parameters which we studied? The first was the asymmetry of the choroidal outflow. Second was the choroidal vessel densitometry. The third was the ampulla distance from the optic nerve. And fourth was the diameter of the prominent choroidal vessels. How do we do it? We take a FA image and the ICG image, we overlap them together, and we basically delete all the translational as well as the rotational artifacts. It gives us a subtracted image. Now this subtracted image is free from the retinal vessels and only contains the choroidal vessels. This registered image is then subjected to thresholding, either adaptive thresholding or a global thresholding, and we get a resultant final image. The advantage of thresholding is that the choroidal vessels are now binarized, either white pixels or the black pixels, and now because it is pixelated, it is easier to quantify these all the parameters which I talked about. So first of all, coming on to the asymmetry of the choroidal outflow. So this is basically studied in terms of the brightness of the pixel intensity in each of the quadrants. So the quadrant with the minimum brightness was subtracted from the quadrant with the maximum brightness to determine the asymmetry of the choroidal outflow. How do we do it? Let me show you the video. So this is basically the interface for the Python program. So once the registered image is being selected, it is being uploaded into the Python program and we click on run all. So we have all these mathematical models. It will basically analyze the image, will divide the image into 4 equal quadrants, select the region of interest. So you see we have gotten these 4 quadrants, and ultimately it will calculate the pixel intensity of the brightness of each of the quadrant. Now you subtract the quadrant with the minimum brightness from the maximum brightness, and you get the asymmetry of the choroidal outflow from that particular eye. Second is the choroidal vessel densitometry. Again, the registered image is being uploaded onto the Python. In this case, adaptive thresholding is applied, and the choroidal vessel densitometry is calculated by calculating all the white pixels. So the average of the white pixels divided by the total number of pixels will give you the choroidal vessel densitometry. So the region of interest is selected, and at the end of the analysis, you get the density of the choroidal vessels in that particular eye. Third was the ampulla distance from the optic nerve. So for this, again, the image is being uploaded onto the Python program. Now this is important because here we need to actually mark the ampullas. So first of all, as the image is being uploaded, we'll get some coordinates. So here, once we click on the optic nerve, you see we get these coordinates. So these coordinates have to be copied and have to be put into the formula for the origin of the image. Similarly, we'll select all the ampullas. So we click on the ampullas, we get these coordinates. So now we copy all these coordinates and we put up into the formulas for the ampullas. So by using Euclidean distance formula, once we have put up all the coordinates of the ampullas, that is the ampulla 1, ampulla 2, ampulla 3, and ampulla 4, at the end of the analysis, this would give us the distance of the ampulla from the optic nerve in each of the quadrant. And lastly is the diameter of the prominent choroidal vessels. So for this, again, the image is being uploaded. So this is one of the parameters which has never been studied before. So we actually try to look at the diameter of the prominent choroidal vessels in each of the quadrants. So something like this will come up. So the algorithm will automatically mark all the prominent choroidal vessels and will give us the mean value of the diameter of the prominent choroidal vessel in each of the quadrant. And if you feel that some of these vessels have been missed, you can even manually mark it, and it will then give you the values accordingly. So now coming on to the results, so a total of 31 cases and 14 controls were included. And amongst the cases, we have all sorts of posterior uveitis which were included in a study. So the average asymmetry of the choroidal outflow was about 14.89 pixel units, and it was more or less similar in all the quadrants, the outflow. Now coming on to the choroidal vessel density, the choroidal vessel density was about 0.36. So it does not have any unit because it is just a ratio of the white pixels to the total number of pixels. The diameter of the prominent choroidal vessel, the distance of the vortex ampulla from the optic nerve, it ranged from about 10.83 to 11.45 millimeters, and it was more or less similar in all the quadrants. And the diameter of the prominent choroidal vessels was roughly about 0.37 to 0.4 millimeters, and it was again more or less similar in each of the quadrants. But when we compared the cases with the controls, we found that though the asymmetry of the choroidal outflow was more or less similar, but the choroidal vessel densitometry in the cases was significantly lower as compared to controls. Similarly, the diameter of the prominent choroidal vessels in the inferior quadrant in the eyes which were affected by uveitis was significantly more as compared to the controls. And the distance of the ampulla from the optic nerve was more or less similar again between the cases and the controls. So we believe that the low CVD in uveitis size is primarily because there is a persistent and a long-standing inflammation of the choroid, which tends to cause some secondary alteration in both the choroidal vessels as well as stroma. As far as the increased caliber of the prominent choroidal vessels is concerned, we are yet not sure and whether it has a role to play in the pathogenesis of posterior uveitis, or is it actually a phenomena secondary to the persistent inflammation in the eyes. It is just yet to be explored. So just to conclude that our study has shown that the CVD was markedly decreased and diameter of the prominent choroidal vessels in the inferior quadrant was significantly increased in posterior uveitis as compared to the control group. And our results indicate that the meticulous quantification and analysis of such parameters can assist clinicians and researchers in better understanding the intricate changes which are happening in the ocular vascular anatomy, particularly in pathologies like posterior uveitis, and it can provide us an objective tool for monitoring of the disease, and can even help us pick up some subclinical disease activity in the other eye or in the same eye. Thank you.
Excellent. Excellent talk and that great work. I think it should have gone to the Colonel Rangachari Award session in the best uveitis paper. I was in the Rangachari session. So it's a wonderful work. Thank you. Congratulations, you and your team, for the excellent work. Thank you very much. We'll go to that next paper. Next paper is a national survey on the practice of uveitis among ophthalmologists in the Philippines, and this will be presented by Dr. Jose Carlo Artiaga. Dr. Artiaga is here. Okay, go ahead.
Okay, good morning, everyone, and thank you very much for this invitation to speak. So I'm here to present on behalf of our fellow Dr. Lester Tan as well on some data from the Philippines. So uveitis is a group of inflammatory eye conditions which tend to be a challenge to diagnose and manage, and may ultimately lead to blindness. And in this paper, it was estimated that blindness from uveitis only accounts for 10 to 20% in developed countries. However, this can be as high as 1/4 of all cases in developing countries. However, there have been a few studies exploring the epidemiology or distribution of uveitis in the Philippines. And most of these studies are limited to large tertiary centers in Manila and may not actually be representative of more common cases that we see in everyday practice. Uveitis in the Philippines is not practiced by uveitis subspecialists alone. This is due to the fact that there are only a few of us fellowship-trained uveitis subspecialists. So the Philippine Ocular Inflammation Society is limited to less than 30 members. Over to your right is an infographic showing that most centers do not have uveitis specialists in our country. This is complicated by the fact that there is a lack of studies, especially guidelines, to help ophthalmologists manage these cases. So what has been working for us, especially in the field of uveitis, is the use of surveys to reach consensus in expert opinion in diagnosis and management of uveitis, such as the COT study by Professor Gupta and a previous mentor, Professor Pavicio. So surveys in itself provide a useful tool in estimating disease epidemiology, and this is one of our motivations in pursuing this study. So the purpose of this paper is therefore to determine the practice patterns of ophthalmologists in diagnosing and managing uveitis in the Philippines. Specifically, we looked into real-world reports of etiologies in the field, preferred approaches to various clinical scenarios, self-assessed skills, as well as referral patterns to help in the management of uveitis patients. So our method was a cross-sectional survey that ran for a span of 1 month between October and November the previous year. The survey linked and infographic was disseminated via Viber to the official channel of the Philippine Academy of Ophthalmology and shared among sub-channels of Filipino ophthalmologists. The survey was composed of 34 questions with the following breakdown, and the questions were drafted and pre-tested prior to dissemination. We only pursued descriptive statistics in this study and did not feel like associations will be helpful considering our demographics. So here are our results. We had a total of 87 respondents, representing about 15 out of the 17 geographic regions of the country. Almost half of our respondents were early career ophthalmologists, but a good percentage were actually senior. And a majority of our respondents have experience in both private and government practice. In terms of specialization, our respondents were fairly distributed between GOs and subspecialists, and among subspecialists, retina were the most represented, and the uveitis specialists were only 10% of the population, which we believe reduced bias. So in terms of frequency, the largest proportion of respondents report seeing a uveitis case every week. In terms of ranking, anterior uveitis was the most common by anatomic location, while idiopathic was most common general etiology, and this is in keeping with large-scale international studies. Of note is that infectious cases were more common than non-infectious uveitis. We were also able to determine the most common types of uveitis identified by our colleagues in the field, which I think is most interesting for us. For infectious, these are tuberculosis, toxoplasmosis, and cytomegalovirus, or CMV, which are likely reflective of our known endemicity and seropositivity of the first two. Meanwhile, the high CMV rate is likely influenced by the still rising incidence of HIV in our country. The autoimmune causes, which were less common than infectious, were led by lens-induced VKH and SLE, and the frequency of lens-induced uveitis likely reflects something between our cataract practices and the expertise of our general ophthalmologists. VKH consistently ranked in the singles among the top non-infectious causes in the previous studies that cited, while SLE being a finding warrants further investigation. So our study looked into the self-rated skill of our colleagues and found that there was only fair skill in requesting for and interpreting systemic workup. Most workup were performed for intermediate, posterior, and panuveitis, which is in keeping with recommendations. The following are the systemic routine investigations requested. Most common are CBC, chest X-ray, ESR-CRP in about 90% of cases. FA and OCT were the most common among diagnostics, and ICGA is something that we can work upon. Our respondents are quite confident in starting topical and systemic steroids, but less confident in terms of intravitreal and periocular administration. Meanwhile, in terms of starting non-steroidal immunosuppressive therapy, there is generally poor self-rated skill with minimal variance in answers. Half of respondents had previous experience in starting immunosuppressive therapy, which is a bright spot, however. And Filipino eye doctors are very likely to refer to a uveitis case. Refer a uveitis case to a specialist, with most already opting to start investigation and management prior to referral. However, a third of us will not be able to refer to a uveitis specialist within our geographic region, which leads to some problems. More than half of our responding colleagues have a rheumatologist, ID specialist, and immunologist at their own hospitals, which is a good thing to see. So these are just a summary of our results. So in conclusion, in summary, we report a survey that looked into real-world perspective on the practice of uveitis in our country with wide-arching insight into demographics, preferences, skills, and resources of Filipino eye doctors. Uveitis is not so uncommon in our country as shown in our survey, hence the need to identify gaps in knowledge and skills to properly care for patients. We hope to assimilate these insights on uveitis in the Philippines and the training of GOs and our future uveitis specialists. So I'd like to take this time and opportunity to invite everyone to APVRS in Manila this coming December 11 to 14. And thank you very much for your time and attention.
Thank you so much. Our next speaker is Dr. Jyotirmay Biswas sir. He will talk about the intravitreal interleukin-6 inhibition with vamikibart in uveitis macular edema, final results from the phase 1 Dovetail study.
Good afternoon. I'll be talking on intravitreal interleukin-6 inhibition with vamikibart in uveitic macular edema, final results from the phase 1 Dovetail study. I don't have conflict of interest, but my co-authors has got and which has been enlisted. Uveitic macular edema, as is shown in this picture, is a very important complication of uveitis. It can be detected by fundus fluorescence angiogram as well as optical coherence tomographic angiography elegantly. IL-6, interleukin-6 play a key role in macular edema. Uveitis macular edema is a sight-threatening complication of non-infectious uveitis. It can lead to a cause of vision loss, affecting around 1/3 of patients with uveitis. Corticosteroids are the mainstay of treatment, but are associated with undesirable ocular and systemic side effects. Interleukin-6 play a key role in the macular edema with dysregulated IL-6 secretion leading to recruitment of inflammatory cells and infiltration in the tissues, blood retinal barrier breakdown, vascular leakage, macular edema formation. Anti-IL-6 antibody, monoclonal antibody, vamikibart, engineered for intravitreal usage, specially engineered for intravitreal delivery. The FC region designed for fast systemic clearance to minimize potential for systemic adverse effects. Half-life after IVT dosing is 7.5 days. It restores blood retinal barrier. Targeting interleukin-6 is a plausible therapeutic strategy for ocular condition with inflammatory component. So, Dovetail assessed the safety, tolerability, and efficacy of intravitreal vamikibart in diabetic macular edema and uveitic macular edema. I'll be talking about uveitic macular edema. Study design Dovetail in phase 1, multi-part, multi-center, non-randomized, open-label, multiple ascending dose study of intravitreal vamikibart. Dose is 0.25 milligram, 1 milligram, and 2.5 milligram. And this has been given in 12 cases in 0.25 and 1 milligram and 2.5 in 13 cases. Primary objective is safety and tolerability. Secondary objective is pharmacokinetics and pharmacodynamics, anti-drug antibody formation, efficacy. Age is more than 18 years. Non-infectious uveitis and concurrent macular edema, CST, central foveal thickness 325 micron more than is taken into consideration. And it has been shown the aqueous humor IL-6 level are elevated in UME independent of uveitis disease activity and type. It occurs in anterior, it occurs in inactive, minimally active, and active, anterior, intermediate, posterior, or pan-uveitis. Dovetail UME cohorts at vamikibart improved vision across all doses in this study, and patients gaining more than 15 letters of BCVA from baseline in the study eye at week 12 is seen 0.25, 1 milligram, and 2.5 milligram, and all patients. Reduced retinal thickness across all dosage and intraretinal vamikibart and subretinal fluid resorption, as is shown in this picture on your right-hand side. You can see that absence of intraretinal fluid, absence of subretinal fluid is observed in all 3 doses of intravitreal vamikibart. In part, in case of adverse event, treatment-related serious adverse events was nil in all the 3 doses, but treatment-related AEA occurred in 1 case of vamikibart. Vamikibart was found to be well tolerated in all doses with no treatment-related serious adverse effects, IOP increases, or new cataracts. Uveitis worsening or flare was reported in 6 patients, that is 16% patients. All events are reported as unrelated to the study treatment and associated with underlying disease activity, that is uveitis. I have just given 2 examples, and this is that the uveitis is associated on the top and ankylosing spondylitis. Systemic methotrexate patient was receiving. Vamikibart 2.5 milligram is given. BCVA changes from baseline was 25 letters. Second case is an idiopathic anterior uveitis. Vamikibart dose is 1 milligram. 3 doses was given. BCVA changes were seen of 19 letters. So the exploratory analysis of inflammation score has found to be a grade 0 in anterior chamber inflammation seen in majority of the cases in all the 3 groups of drugs. Proportion of patient vitreous grade 0 was seen in 0.25, 1, and 2 milligram, 2.5 milligram. So in conclusion, vamikibart is a humanized interleukin 6 antibody engineered for intravitreal use in patients with retinal diseases. Final results from the phase 1 dovetail all the patients with uveitic macular edema found that vamikibart improved vision and retinal thickness in OCT in all dosing cohorts. It was well tolerated with no treatment-related serious adverse effects or new cataracts or IOP increase. Based on these phase 1 findings and supported by pharmacokinetic and pharmacodynamic results, phase 3 MEERKAT and SANDCAT clinical trial program in uveitic macular edema was initiated. Thank you very much for patient hearing.
Thank you so much, sir. Any questions for Dr. Jyoti Biswas? Yeah.
Thank you very much, and thanks for the presentation. Very wonderful work. I would like to ask if the patients also have systemic diseases associated with uveitis. Would you also recommend to give top up in this case in terms of the systemic treatment with anti-IL-6 in the systemic and in the intravitreal in the future works, or would you consider to, because of this high efficacy, if there's no such inflammation, probably just go intravitreal and the systemic, we can refrain from using a lot of biologics that may be costly? Thank you.
So this is a wonderful question. But the basic disease process and uveitic process has to be treated, definitely. But uveitic macular edema component can be treated with the IL-6 inhibitor from the results of this study.
Thank you, sir. So, Dr. Vishali, she's not available, but we have a recorded presentation from her, and the topic is IL-6 inhibition with vamikibart in patients with uveitis macular edema, the phase 3 MEERKAT and SANDCAT trials. Can we have the presentation?
A very good morning. I will be presenting on IL-6 inhibition with vamikibart in patients with uveitic macular edema, the results from phase 3 MEERKAT and SANDCAT trials. I am Vishali Gupta presenting on behalf of the group, and I have no financial disclosures to make. Now, when we talk of uveitic macular edema, we all understand it's a sight-threatening complication which causes visual loss, a moderate one, affecting nearly 1/3 of the patients. And of course, there is a high unmet need for novel non-steroidal therapies which could target specific mediators of immune response for improved outcome. Because we are able to control the inflammation, but somehow we do need a very strong therapy for uveitic macular edema. So in short, this is the requirement, which is the unmet need, and vamikibart is the new drug therapy, an anti-IL-6 monoclonal antibody, which has shown a promising results in phase 1 data. Now, when we talk about IL-6, all of us do understand that IL-6 has a major role to play in the inflammation as well as in angiogenesis. It's a pleiotropic cytokine which is implicated in wide variety of biologic processes, and dysregulated IL-6 signaling leads on to angiogenesis, fibrosis, inflammation, as well as the breakdown of blood-retinal barrier, which in turn is the cause for macular edema. Therefore, if we need to control the macular edema, we need to target the blood-retinal barrier disruption. So there is a preclinical and clinical evidence supporting that if we target IL-6 in uveitic macular edema, it is going to yield good results. The intravitreal anti-IL-6 antibody attenuates the inflammation in experimental autoimmune uveitis, as well as the clinical studies with systemic IL-6R inhibition in non-infectious uveitis have demonstrated a specific benefit in uveitic macular edema. So, anti-IL-6M antibody, which is vemicibart, engineered for intravitreal use, and this is actually a very specifically engineered for intravitreal delivery, and in short, it helps in restoration of blood-retinal barrier integrity by inhibiting both cis and trans IL-6 signaling. It provides a very rapid and sustained suppression of AH, aqueous humor IL-6 at all tested doses. The studies MEERKAT and SANDCAT phase 3 in uveitic macular edema. Total of 26 countries are participating, and these are the two ongoing identical global parallel multicentric randomized double-masked sham comparator control trials to evaluate the efficacy, safety, pharmacokinetics, and pharmacodynamics of IVT vemicibart in patients with UME secondary to non-infectious uveitis. Adult patients with UME secondary to NIU and a central thickness of more than 325 micron plus the vision decrease due to UME with ETDRS score of 73, 19 letters, all the non-infectious uveitis etiologies and anatomical types were allowed. Active or inactive NIU is allowed, and prior systemic and local therapies permitted. Concomitant use of immunosuppression and biologic, which we all understand is very important for the control of inflammation too, is permitted. So this is how the patients who are randomized, they are into 1:1:1 ratio, where arm A gets 1 milligram, B gets 0.25 milligram, and C receives a sham. Of course, there is a rescue treatment if wanted at any time from week 4 onwards, and this graph here represents the time point when the interventions are being done. The primary endpoint is the proportion of patients with more than 15 letters best corrected visual acuity gain from the baseline at week 16, as well as there are a couple of secondary endpoints. The key secondary endpoints is the improvement in the vision as well as anatomical change, whereas the secondary endpoints do include pharmacokinetics, safety issues, and the exploratory endpoints are biomarkers, uveitis activity. So to conclude, vemicibart represents a potential non-steroidal immunomodulatory treatment option for local intravitreal delivery in patients with uveitic macular edema, and both MEERKAT and SANDCAT are two identical global phase 3 trials designed to investigate IL-6 signaling inhibition with intravitreal vemicibart in patients with UME. Both are ongoing, and we do hope to share the results when the trials are complete. Thank you very much once again.
Thank you, Dr. Bishali. I know you are not hearing, but anyway, we'll convey my regards to you. With this, we conclude the session, rapid fire session of rapid fire session of intraocular inflammation, uveitis and scleritis update session. And I like to thank all the audience and all the speakers who participated in this session. Thank you very much, and have a safe trip back.
So we can have a group photograph with this.
We can have a group photograph. All the speakers requested to come.